Hello, my name is Philip Lay, and this presentation is entitled OCT Macula Interpretation. I have nothing to disclose. This is a standard macular OCT scan through the fovea of the left eye with the layers annotated. One way to remember which layer is which is just to think about the layers that are bright or hyperreflective. The two brightest layers are typically the retinal nerve fiber layer and the RPE Brooks complex. In the middle of the retina, the plexiform layers are hyperreflective. The nuclear layers are dark. There's a triplet of bright lines, which is the EZ, IZ, RPE Brooks. And that's ellipsoid zone, interdigitation zone, and RPE Brooks complex. Underneath RPE Brooks is the choroid, and then the solid sclera. The choroidal thickness under the fovea should be about 270 microns, or about the thickness of the fovea itself. Segmentation is very important in OCT analysis. The software will automatically attempt to annotate the important layer boundaries of the retina. This allows the calculation of parameters such as retinal thickness and volume and nerve fiber layer thickness. Obviously, this is affected by image quality and patient movement. Segmentation is much more likely to be accurate when the eye is closer to normal. Most of the images I will be showing will be B scans and reports from the Zeiss device, but everything we talk about is applicable to virtually all device brands. The terminology we use is adopted from ultrasounds, where an A scan is an amplitude scan, where the degree of reflectivity was displayed as a height or amplitude. The problem with an A scan is that we're using two dimensions to display reflectivity along one dimension. Therefore, the brightness scan or B scan was developed. In a B scan, the reflectivity along the beam is displayed as a brightness. So in a 512 by 128 cube scan, this means that there are 512 scan positions along the nasal to temporal axis, or x-axis, and then 128 points along the inferior to superior, or y-axis. The third dimension of the cube is the depth of the A-scan itself, or the anterior-posterior dimension of the eye. So within this report, the ILM to RPE is the thickness of the retina. So the machine segments the ILM, and then it segments the RPE, and it calculates that thickness, and that's shown here as well as here. And then each surface is shown individually. The ILM is shown and the RPE is shown. The distance between the two is calculated as a thickness, and then the volume of the entire retina is calculated as a cube volume. So one of my first recommendations is to look at the entire report. On this OCT macular report, there is clearly subretinal fluid here, and that shows up as thickening of the retina here and here, as well as in the numerical measurement of the thickness of the retina. But there's an area where the thickness calculation fails, and that's this area here. This is usually due to poor image quality or media opacity, which causes the segmentation to fail. Another cause is when the retina is off the screen. In this case, we can see a hint of what's happening on the vertical B-scan and along the RPE surface image here. So here we can see why the retinal thickness calculation failed. It turns out that there's a choroidal mass which has elevated the retina, and the surface of the retina, or the ILM, was not visible here. Therefore, the machine could not segment the ILM and could not calculate the ILM to RPE thickness. This patient had an idiopathic inflammatory choroidal mass which resolved with steroids. Now we're going to start looking at pathology, and we'll start in the vitreous. This is an example of an OCT scan showing asteroid hyalosis. You can see that the reflectivities are relatively large. The ones on the lower half of the screen look like they're deep to the retina within the choroid, but this is actually a reflection. They're actually in the vitreous. Contrast the previous slide with this slide, which shows vitritis. The background brightness has been increased to highlight the cells. They are significantly smaller than the asteroid that we saw on the previous slide. Next, we come to vitreoretinal interface abnormalities. Commonly, you'll see vitreomacular adhesion, vitreomacular traction, and epiretinal membrane. And I'm not showing examples of these because they are relatively common. I am showing an example of nerve fibrillary schisis, which is seen in high myopes or patients who have a posterior staphyloma, as seen in the ultrasound B scan in the upper right corner. So what does this look like? Well, first we know that this is a right eye because the nerve fiber layer is to the right side of the fovea. Temporal to the fovea, there is hyperreflectivity and thickening of the inner retina. There is shadowing underneath the hyperreflectivity, as evidenced by hyporeflectivity of the RPE. The RPE is very obvious nasally, but not temporally. So we can see that what was actually happening was a central retinal artery occlusion with preservation of the territory supplied by a cilioretinal artery. We can correlate the area of edema temporally with the whitening of the retina on the color image. Unfortunately, the patient had had a CRAO in the fellow eye and had not come in to seek treatment. Here you can see inner retinal atrophy on the entire B scan. The ganglion cell complex thickness is a relatively new parameter utilized frequently in evaluating optic neuropathy because it represents the ganglion cell bodies that form the nerve fiber layer. It is measured between the bottom of the nerve fiber layer to the bottom of the inner plexiform layer or the top of the inner nuclear layer. We use these boundaries because they are relatively easy to segment. Here you can see my drawing of the segmentation of the ganglion cell complex. In this patient, clinical exam revealed a focal nerve fiber layer defect at about 10 o'clock on the optic nerve. This defect is also visible on the nerve fiber layer deviation map. But the patient's average retinal nerve fiber layer thickness was normal in both eyes. Ganglion cell complex analysis shows an arcuate thinning, which is seen on the deviation map here, and as thinning in the superior sector of the ganglion cell complex map. The left eye is relatively normal. So what's happening on this slide? This is a horizontal B-scan through the fovea. Again, I typically look at the nerve fiber layer first, and it's missing. It should be on the right-hand side because this is the right eye, as we can see on the thumbnail image. But if we zoom in to the nasal macula, the nerve fiber layer appears to be missing. These are the RNFL and GCC reports for that same patient. We can see that although the average RNFL thickness is in the normal range, there are areas where the retinal nerve fiber layer deviates from what we expect. But more telling is the GCC thickness map, which shows severe thinning in both eyes. This patient has autoimmune optic neuropathy and had vision in the 2200 range, which improved to 2080 after receiving steroids. Here is an example of an opacity within the metal retina. It's a large microaneurysm with adjacent exudate. The OCT shows a focal area of hyperreflectivity. There's shadowing behind the hyperreflectivity. This is the clinical appearance and 10-2 visual field result for that same patient. It shows the microaneurysm with exudate about 1 millimeter inferior to the fovea and the corresponding visual field deficit about 3 degrees superior to fixation. Paracentral acute middle maculopathy was originally described by Saraf and colleagues, and it's a result of ischemia in the intermediate and deep capillary plexus, often associated with some sort of vasculopathy such as diabetes or vein occlusion. And on the OCT, you'll see a hyperreflectivity between the inner plexiform and outer plexiform layers, which later results in atrophy. Again, here's the hyperreflectivity. Within the middle retina, you can also see edema. Commonly, you'll see PEDs with edema in exudative age-related macular degeneration. Subretinal fluid is also a very common OCT finding. Here again, the fluid is between the RPE and the neurosensory retina. These are a couple of different types of PEDs, or pigment epithelial detachments. The different types of PEDs include drusenoid PEDs, serous PEDs, hemorrhagic PEDs, fibrovascular PEDs, and then the mixed subtype, which is typically mostly serous with a small amount of fibrovascular material. The key is to follow the RPE band. So here, for this fibrovascular PED, there's a separation between Brooks and the RPE here. And the area between the two is the PED. In this serous PED, RPE goes up while the Brooks is here. This is a fluorescein angiogram late in the sequence, and there are multiple abnormal areas. Temporally, you can see so-called stippled hyperfluorescence, which used to be called occult CNV and is now called type 1 CNV. There is a fibrovascular PED, but the choroidal neovascularization remains under the RPE, and so the RPE is overlying the CNV and it's not that bright. This is in contrast to the nasal portion of the lesion, which has a type 2 or so-called classic CNV. Here the CNV membrane is above the RPE, and so the fluorescein is not obscured by the RPE layer and thus is bright and homogeneous. Centrally, there's more mature type 2 CNV, which is not as bright because it's not very leaky. This is the OCT B-scan through the lesion. Temporally, there is an occult or type 1 lesion with the fibrovascular PED below the RPE. So here's the lesion, and you can see that it is underneath the RPE. Nasally, there is the classic or type 2 lesion with the CNV above the RPE. That's this material here. Here's a very complex OCT scan in a patient who has exudative AMD or more likely polyphoidal choroidal vasculopathy. On the B scan, nasally, you can see the fibrovascular PED. You can also see intraretinal fluid or cysts, and then there's subretinal hemorrhage temporally. Again, if you trace the RPE, it's here, and then it disappears in the shadow of the hemorrhage. The hemorrhage is this area. And that's seen in the color photo beneath. This is another patient who has polyphoidal choroidal vasculopathy. The ICG shows polyps within the inferior macula. There are two B scans showing polyps. This one here representing this polyp right here, and then another B scan more inferiorly showing a very large PED. The top OCT scan shows before photodynamic therapy, and the bottom OCT scan shows after treatment of the polyps by PDT. This slide shows RPE atrophy in the fovea. There are three features of RPE atrophy on OCT. First is loss of the RPE Brooks thick band of hyperreflectivity. If you look at the RPE outside the fovea, it looks relatively normal and thick. In the area of atrophy, you've lost the RPE Brooks interface, so you just get a thin Brooks membrane. Second is atrophy and thinning of the overlying outer retina. As the photoreceptors die, the other layers tend to collapse downward. This causes a so-called waterfall appearance, meaning it tends to look like things are collapsing into the atrophy. The third feature is hypertransmission of the OCT beam into the choroid. This slide shows iatrogenic RPE atrophy caused by focal laser scars in a patient who had a branch retinal vein occlusion and developed macular edema. again, we see the three features of atrophy on OCT. You see thinning of the Brooks RPE band of hyperreflectivity, loss of the overlying photoreceptors, and hypertransmission into the choroid. This patient also has RPE atrophy, but it is outside the fovea, and so she has a relatively good visual acuity, but does complain of problems with her vision. You can see that she has parafoveal RPE atrophy with all the features that we've talked about. And so that patient had plaquenil toxicity with parafoveal RPE damage. You can see on the autofluorescent image that there is a bullseye maculopathy with a ring of hypoautofluorescence surrounding the fovea. The hypoautofluorescence is due to RPE atrophy and lack of lipofuscin and other autofluorescent material because there is no RPE. Unfortunately, the RPE atrophy continues to progress and enlarge for several years despite cessation of the drug. This patient is a teenage girl with 20/60 vision in both eyes. On the OCT scan, you can see foveal loss of the EZ band here, as well as generalized thinning. The multifocal ERG demonstrates markedly reduced responses in the central 20 degrees, as seen here. The patient's responses are in black, and the expected responses are in red. The responses are increasingly normal as you move into the periphery. The autofluorescence image shows a bullseye pattern of hyper and hypo autofluorescence. Genetic testing revealed that this patient is a compound heterozygous for the ABCA4 gene, which is Stargardt's. That means that she got one abnormal copy from her mother and a different abnormal copy from her father. So what's happening here? This is a horizontal B scan close to the fovea in the left eye. There's an ERM. There is RPE atrophy with overlying outer retinal atrophy and hypertransmission into the choroid nasally, starting about 1 millimeter from the fovea, and there's a similar region temporally. The choroid is thin. So that patient has choroideremia, confirmed by genetic analysis. In the Optos pseudocolor image and green light autofluorescence image, you can see that the area of preserved RPE is here, and that corresponds exactly to this region here. Choroideremia is one of the few diseases where the fluorescein angiogram looks very similar to the ICG angiogram. Because of all the RPE atrophy, you can actually see the fluorescein in the choroid. So what do you notice here? Well, so this is an OCT macular report in the left eye. You can see that the foveal thickness is relatively normal. The thickness map, ILM to RPE, shows that there's some thickening nasally. That's also shown on the B scan. This is the B scan blown up, and you can see that the nerve fiber layer looks somewhat thicker than normal. So that patient had HLA-B27 uveitis, and she developed 3+ disc edema due to inflammatory perineuritis. The initial retinal nerve fiber layer thickness measured 258 microns in the left eye and was normal in the fellow eye. She was started on oral steroids. After a couple weeks of oral steroids, the nerve fiber layer thickness decreased to 211 microns and then 150 microns. She is continuing her steroid taper, and her visual acuity is 20/20 at this point. And finally, the top image is a horizontal B scan. The bottom image is a vertical B scan. In the top image, you can see hyperreflectivity within the vitreous, which likely represents vitritis. The hyaloid has begun to separate. There is inner retinal edema, subretinal fluid, and subretinal and sub-RPE hyperreflectivity. This is subretina, and this is sub-RPE. And so that patient was a 57-year-old woman with relapsed leukemia. She was immunocompromised. PCR showed that she had Epstein-Barr virus retinitis, which you can see here as retinal whitening. She also had subretinal infiltrates, probably leukemic. She was treated with intravitreal foscarnet and chemotherapy. So in summary, try to look at all the parts of the OCT macula report. Try to look at all the B scans, especially in AMD and in unusual cases. And pathology typically falls into one of the following. Either things are too thick, i.e. edema or inflammation, or they're too thin, meaning atrophy, or there's something that should not be there. Thank you for your attention.